there's just so much.
You're listening to a Mamma Mia podcast.
Hello, Australian women. Welcome to your full body health check. I'm Claire Murphy. We're talking about sleep today, and if my sleep pattern is anything to go by, I've been told because I wake up at 4 a.m. for work, have done for the last, 20 years or so, I'm going to die 10 years earlier than I otherwise should have. Is that true? I guess we'll find out.
Goodness. And I'm Dr. Mariam, and I'm 100% a light sleeper.
Oh, no.
Every light switch, every cough, I am up. But give me the right pillow and a home that doesn't have any kids or a husband in it,
Yep.
and I am out like a light.
Love that. We all need a sleep holiday. Coming up today, of course, talking about sleep disorders, can't sleep, can't get enough sleep, why some of us sleepwalk. Yeah, we're probably going to have a nap during this. What really happens to you if you go without sleep for a bit too long. And we're going to also do a quick consult for Carmen today. She's procrastinated on a couple of health issues, and now she's a little bit too terrified to get anything looked at. So we're going to try and help you out today. But next, I'm about to share some things that I found out recently about what's happening in the medical world when it comes to reducing your risk for getting dementia. One of them is going to make some of us very, very happy. So let's go to med school.
Welcome to med school.
A couple of news stories that I've seen recently, Mariam, about reducing your risk for dementia. Two very interesting ones. The first one is a new study from Stanford University, which shows that the shingles vaccine, which I know my parents have been getting, they're in their late 70s, early 80s, is actually linked to a reduced risk of dementia. So we're talking like two birds, one stone.
So that study did find that it could potentially cut your risk of dementia by around 20%. So researchers followed close to 300,000 people and found those who got a certain vaccine had lower dementia rates over 7 years. The theory is it's thought to reduce brain inflammation that might be triggered by the virus that causes shingles. However, in Australia, we use a different vaccine, but it may offer similar brain benefits, though more research is needed. So who can get the vaccine for free in Oz under the National Immunisation Program? Anyone over the age of 65, Aboriginal or Torres Strait Islander people over the age of 50, or people over the age of 18 with certain high-risk conditions. But here's the catch. Most experts recommend getting the vaccine from the age of 50. If you're over the age of 50 and you're thinking about, getting maybe that extra added layer of benefit, then speak to your GP about getting it privately.
The other study, which is just quietly my favourite, this one came from the Tokyo Metropolitan Institute for Geriatrics and Gerontology. They found that dog owners are 40% less likely to develop dementia compared to those without a canine companion. The researchers think this is possibly linked to a lot of different benefits like physical activity. Obviously, you'll be taking your dog for a walk. The social interactions too, and if you've ever owned a dog and gone to a dog park, like conversation happens or people will just approach you to talk about your dog, which is really nice. And there's also some evidence to suggest that the love that you receive from your dog, which is unconditional and it's going to make me cry, increases your oxytocin levels, which is known to help preserve memory. Now, look, this is fabulous news for dog owners. Unfortunately, I'm so sorry to break this to you, cat owners. For your feline friends, it's not the same result. And I think we all know why.
Fair enough.
We're not sure if cats love us.
Person.
Well, I love cats, but we're not really sure if cats love us. So sorry, guys. Okay, I think it's time to get into today's checkup. So we are about to talk about sleep.
It's time for the checkup.
Sleep is so important. We get told it all the time, and it is the one thing that we probably mess around with a little bit too much. Sometimes too, your body has decided that for various reasons, it's no longer going to be a thing for you. Sleep is going to be disrupted. Children could be one of those reasons. You and I are both parents, you two tiny twins, so like doubly sleep deprived. But for others, there are actual sleep disorders that can really interrupt your chances of getting the rest that you really need for your best health.
Yeah.
So if you could, Miriam, can you run us through some of the most common sleep disorders? So let's start with insomnia, like what causes it? How do you recognize it in your patients?
So insomnia is one of the big ones we see in general practice, and it's basically trouble falling asleep, staying asleep, or waking up too early and not being able to go back to bed. And it's despite having the time and opportunity to sleep. And of course, it has to be affecting your daytime function. So we're talking fatigue, poor concentration, irritability, that kind of thing. So we kind of categorize it in short-term and chronic. So acute insomnia is like lasting roughly a day or two, and it's usually due to acute stresses like a relationship breakup or an exam or illness or jet lag. However, it can easily develop into chronic insomnia if you've got predisposing factors. Chronic insomnia happens when it's been going on for roughly 3 months or more and often has multiple layers. So think mental health conditions like anxiety or depression, unhelpful sleep habits, or what we call hyperarousal, where basically your brain just won't switch off at all at night. One myth that I really like to break is insomnia isn't just bad sleep hygiene. A lot of people know that habits matter, but often they already know the rules and they're trying really hard to
so they've already got like a bunch of steps in place and it's still not working.
That's right. And they're stuck in this pattern that their brain just won't let go of. This is where evidence-based treatment like cognitive behavioral therapy for insomnia comes in. It's the gold standard. It works better and longer than sleeping pills, and it's completely safe. I often get patients come in and they're like, I can't sleep, I need pills. Pills are a short-term fix. They're not going to help you for an issue like chronic insomnia. In terms of how I recognize it in my patients often present as what I say is wired and tired, right? So usually starts with something like, I just can't switch off at night. I'm so exhausted, but I'm wide awake. So if you're in bed looking at the ceiling at 3 a.m., you're definitely not alone. There is help. Start with that simple conversation with your GP.
Okay. And what about some of the others? Because insomnia is the biggest, but there's also things like sleep apnea and narcolepsy and sleepwalking too.
Yeah. So sleep apnea, OSA, obstructive sleep apnea, it's like the snoring cousin of insomnia.
My husband has it. It has been the cause of many fights right up until he got a CPAP machine.
Yeah. And I'm sure you've got lots of issues with the CPAP machine
I
now
actually
as well.
don't,
Oh,
but
really?
I'll talk about that a little bit more because people have this impression that CPAP machines are like sleeping next to Darth Vader. It is not.
Well, now the new ones are great. Yeah.
So quiet.
Yeah. Well, if they've got it on right?
Oh, my
If
God,
there's
yes.
no
He
leaking
forgets
air.
to put it on and sometimes it slips off his face, so I wake up to there's a bit of that.
Yeah, so obstructive sleep apnea, super common but often undiagnosed, unfortunately. So what's happening basically during sleep, the muscles around your throat start to relax, which is totally normal. But in some people, they relax a bit too much. It causes the airway to partially or fully collapse, which blocks airflow. So your body kind of gives you a bit of a gentle nudge to kind of like wake up, like, please don't die.
I need some oxygen.
Hang on, I can't breathe. So you get these like briefly wake ups. If you think about it, it's quite exhausting for your body just to continually trying to keep you alive. So these people wake up and they're exhausted. They're like, hey, I've been in bed 10 hours. Why do I feel this way? Classic signs are loud snoring, gasping or choking during sleep, and waking up feeling unrefreshed, and daytime sleepiness that feels more like a full body fog. People will say, I can sleep at any moment at my desk or in the car, like I'm just really exhausted. Risk factors, so weight is a big one, especially if you've got fat deposits around your neck and upper airway, but it's not just about body size. There are a lot of people that are quite lean and have
my daughter had obstructive sleep apnea when she was 2
Yeah,
and
that's
had to have her tonsils and adenoids removed.
Yeah, that's right. Anatomical factors come into play, so small jaw, large tonsils or nasal obstruction. Men, postmenopausal women, and people with a family history are at higher risk of the condition. And here's the kicker. If left untreated, it's linked to conditions like high blood pressure, type 2 diabetes, heart disease, and even stroke. And they're also at increased risk of accidents. So you think workplace accidents or motor vehicle accidents.
And if you want to recognize if you're sleeping next to someone who has sleep apnea, I'll give you a sound.
Yeah, right.
So it'll go quiet for a minute and then you'll hear... That is sleep apnea. Like it's because their whole body has gone like convulsed to wake them up so they can get some air in.
And diagnosis is quite simple. Usually starts with a sleep study. And these days you can do them at home or you can do them in a formalized.
Yeah, my husband did it at home.
And treatment, quite common, is a CPAP machine, which we spoke about. But for some people, if there are anatomical issues, an oral appliance or even surgery, depending on the cause. So if your partner has been complaining about your snoring or those sounds that Claire just made, I wouldn't ignore it. Definitely have a chat to your GP about getting a sleep study.
There's also lots of pharmacies that specialise in
that's right.
sleep studies and stuff now too. So you might not even necessarily need to go to the GP, go to them, do a sleep study. So there's a couple of ways you can do that.
Yeah,
right?
That's right.
If we do have sleep issues though, like I know like sometimes you can go to a GP and say, I'm really tired.
Yep.
And
a lot of people do.
It feels like a very beige thing to say. Like how do you know you're getting the right treatment for your particular issue?
I would say if you have an issue with sleep, do not wait till it's a full-blown problem. Sleep is such an important part of your life, and we know sleep deprivation comes with lots of issues. So first off, your GP is going to be your first point of contact and just say, I'm having struggles with sleep. They'll talk to you about your sleep patterns, your lifestyle, your symptoms. They should do some questionnaires with you as well. And the next step really depends on what's going on. So if it's insomnia or daytime sleepiness, they might suggest some lifestyle changes and refer you for some CBTi or even a sleep study if needed. If you're snoring or feeling tired all the time, then they'll most likely refer you off for a sleep study or send you off to a sleep physician. And the same for conditions like narcolepsy or complex parasomnias as well. They'll either refer you to a neurologist or a sleep physician for specialized testing. But yeah, if you feel like you're not getting the answers, it's okay to tell your GP, like, I'm still tired despite doing all these things. Can I get a referral to see a specialist?
All right, on the way, Carmen would like a big kick up the butt from you, Dr. Mariam. So we are going to be helping her out. But next we're going to speak to Dr. Kathleen Maddison. She is a specialist in sleep disorders. She's going to get to the bottom of how our hormones, for example, from menstruation to menopause and through pregnancy might be keeping us awake, what things are proven to help with disordered sleep, and even how to handle that chronic sleepwalker in your life. We are talking about sleep today, and even literally just having this conversation is making me a little bit sleepy. I'm also obsessed with hot water bottles. Even when it gets warmer, I'm still tuck a hot water bottle into bed with me. I'm such a baby, but I love it.
They're the best.
But sometimes even when we're craving sleep and when we know we need sleep, can't even stop thinking about it, our brains don't want to shut down, or they shut down without permission, or they shut down for a bit but not for long enough. So Dr. Kathleen Maddison, an academic and research fellow at the Centre for Sleep Science at the University of Western Australia, is helping us understand why. Now, before we start to chat with Kath, just want to let you know, let's be clear, she is not a doctor. Well, she is, but she's not a GP. So she is a scientist, and she has all the data and all the facts about these sleep disorders, but does not prescribe medication or see patients. So I just want to make that clear. So we're going to kick it off. Dr. Maddison, we're all a little bit obsessed with sleep these days, but scientifically, how much does the average human really need?
The scientific evidence, so from a lot of health bodies, suggests that for adults between the ages of 24 to 65, 7 to 9 hours is what's recommended per night to optimize overall health and well-being.
So that doesn't mean getting 9 hours one night, 18 hours the next, and 2 hours the one after?
No. So I'm very specific with my choice of words there, you would have noticed. No, that's every night. So as a society, I think some of that need to know about sleep is because we are quite sleep deprived. A lot of us have what's called social jet lag, where we sleep a lot shorter during the week because of life. There's no judgment there. There's kids, there's work, there's stress, there's everything else, trying to get your exercise, eat your protein, do it all. And then we play a bit of catch-up sleep on the weekend. And the evidence suggests it's actually quite hard to catch up on sleep.
The next question that we get asked fairly regularly is, why do we wake up at 3 a.m. I am reading that it is due to increased cortisol levels, but if you're to believe social media, we're all obsessed with our cortisol levels and what that means in various things. Is it generally because we are a more nervous and anxious bunch, and 3 a.m.'s when the cortisol level spikes? What's happening?
In terms of being an anxious society, I can't comment on that, but I would suggest just with life stresses and the world as it is at the moment, that we probably are, our anxiety is a little bit lifted. Definitely women are more prone to being anxious or having anxiety type personalities. In terms of the 3 a.m. wake up, it's a really interesting one. It's probably multifactorial. There's kind of two opposing factors that drive our sleep and our wake. And one is our homeostatic drive, which is how sleepy we are. You know, you wake up in the morning and you're not that sleepy. And over the course of the day, your sleepiness kind of builds up. And at the same time, your circadian rhythm, which is your internal body clock, kicks in. When you sleep, you have most of your deep sleep in the first half of the night and some of the more transient, more lighter sleep in the second half of the night. And so when you fall asleep, you actually blow off some of that sleep pressure. And by 3 a.m., you've blown off a decent amount of sleep pressure, but you've also hit a point in the night where you're probably having lighter stages of sleep or more transient stages of sleep. So if anything, a dog barks, a child coughs, you're more prone to wake up, and you've woken up and you've had enough sleep to actually feel quite rested. And then the brain starts going. So that's a really common one. In terms of cortisol does fluctuate throughout the day and is linked to sleep. And there is a peak just before we wake up in the morning. And the easiest way to prevent that kind of behavior is having a really strong sleep schedule, going to bed at the same time, waking up at the same time, and keeping those things very similar, Monday through to Sunday.
Well, can we kick off with our first sleep disorder? What's the most common cause of insomnia in women, and how do our hormone changes like menstrual cycles, pregnancy, menopause, how do they play a role in insomnia?
Really great question. Typically, they think of the 3P model when talking about insomnia. So we have the first P is predisposing factors. We are predisposed by our personality, by our genes, to be predisposed to insomnia. Then we have something called a precipitating factor. And that's something like a stressful event, chronic pain, menstrual pain, anything like that happens, that triggers, and it triggers poor sleep. And then what happens is there's perpetuating factors. And these are things that we do that are good in the moment, but over long term create insomnia type behaviors. So an example would be if you have chronic pain, and you get up at 3 o'clock in the morning and you go get a wheat bag and you sit on your phone and you quickly do some emails and you wait for the pain to subside. And that works really well in that moment. But then what happens is that pain dissipates, but you still are waking up at 3 o'clock in the morning and you still get up and check your email. And so now that thing that you were doing that was really quite beneficial in the moment, the pain is gone, but it's creating this really poor sleep. We do know that female hormones, so ovarian hormones and sex hormones, are linked to sleep quality and quantity and tightly linked. So across the female's lifespan, and I'm thinking of how the biological sex hormones change, specifically estrogen and progesterone, their changes directly impact sleep. So we know that insomnia type symptoms are quite common shortly after ovulation. During menstruation, the cramping and the pain can create some sleep problems as well. Premenopause or perimenopause and postmenopause, those hormones and the fluctuations that occur in those hormones have a really significant effect on overall well-being, overall sleep quality and quantity. And there's an increase in insomnia symptoms and reports of insomnia in women during those times of our lives, unfortunately. But we do know those exist and they are closely linked. There's also pregnancy as well. And pregnancy is another stage of a woman's life that does have an effect and often not a positive effect, particularly in the last trimester on overall sleep quality and quantity.
We know a lot of people might turn to prescription medications where it comes to dealing with insomnia, but are there non-drug treatments? I know that we just recently did a whole section on mind and cognitive behavioural therapy came up quite often. Is that effective for something like insomnia?
Cognitive behavioural therapy for insomnia, so CBTi, is the first line treatment for chronic insomnia. It's not the treatment that's always prescribed, unfortunately, but in terms of the efficacy and also being able to treat insomnia, it is far more effective for chronic insomnia than something like sleeping tablets. The problem with sleeping tablets, great in the acute phase, so you can have acute insomnia, so less than 3 months, you've had a stressful event, you're not sleeping really well. The concern is when that becomes chronic, and that's when you've had this sleep problem, either trouble falling asleep, trouble staying asleep, or waking up too early and they're the definitions around insomnia. If you've had those more often than not during the week and it's been lasting more than 3 months, that would potentially meet the criteria for chronic insomnia if it's affecting your daily functioning. And in terms of the treatment, cognitive behavioral therapy for insomnia, which is provided by a trained sleep psychologist. It can be done online in a digital environment. They can be done in group environments or in a one-on-one session as well.
Well, let's move on to sleep apnea. That seems to be something that's increasingly more common in Australia in 2025, especially in men. But are we seeing the same in women? And are the signs for sleep apnea different between men and women, or are they quite common?
So yes, definitely. Obstructive sleep apnea is on the rise. It is linked with body weight and body mass and also age. And as a population, we are aging. Our baby boomers are taking us through there. The signs and symptoms are a little bit different between male and females. Generally, excessive daytime sleepiness is one of the big ones, but not everyone gets that. Snoring is another one. Women tend to be a little bit bashful about whether they snore or not, and so don't have those conversations as often, but snoring is another big one. Waking up with morning headaches, not making it through the day without a nap. Some of those can be more related to females and how they present with obstructive sleep apnea.
Is a CPAP machine the only treatment we currently have for sleep apnea?
Yeah, so a CPAP machine is one of the primary treatments, but it's not the only treatment, not at all. So for anyone that doesn't know what CPAP is, it's a device that creates a pneumatic splint, so like a blower vac on blower. It's attached to your face via a mask and it pneumatically splints the airway open and prevents it from collapsing. Other treatment options include oral appliances, so like a mouth guard that's fitted by a specialty dentist. But what it does is it pulls your jaw slightly forward and away and pulls with it the tongue from the back of the throat. So it opens up the airway, which is the area of concern. There's some lifestyle changes. So limiting how much alcohol is consumed, managing your weight, exercise is another great treatment, and body position therapy. So for a number of individuals, sleeping on your back can make the condition a bit worse. And so there's some devices that can help train you to sleep on your side. So there are a number of different therapies, not just CPAP. And at the extreme end, you can also have surgical options. The surgical options, some people get great resolution and unfortunately some people get no resolution.
Well, can we move on now to narcolepsy? And I think we all have a bit of a Hollywood idea of what narcolepsy actually is, but can it be mistaken for other conditions like depression or chronic fatigue? And how do you then get an accurate diagnosis? Because we know sometimes we struggle to get our GPs to really understand what it is we're dealing with.
Yeah, so narcolepsy, the cardinal symptom of narcolepsy is excessive daytime sleepiness. Some of the other symptoms that occur is cataplexy, which is where your muscles relax all at once. And I think this is where the Hollywood image comes along as people kind of just fall asleep and with that go from standing upright to lying down. That's not always present in narcolepsy. There's two different types and you don't need to have cataplexy. The other common things are sleep paralysis. That's when you're falling asleep or waking up. While your mind is awake, your body is still paralyzed. And so while it can be quite scary in the moment, it does pass and then you can move. So sleep paralysis is its own sleep disorder in its own right, but is also linked with narcolepsy. And the other one is having hallucinations when falling asleep and waking up. The way to get it diagnosed is to have a really good chat to your GP and get a referral to a sleep clinic. A sleep physician will then assess you having a sleep study, and it'll normally be 2 sleep studies, one in the evening to rule out any other sleep disorders like obstructive sleep apnea, and then one the next day where people are given multiple opportunities to nap and they monitor what stage of sleep an individual goes into when they nap. So there's diagnostic criteria around it.
What about sleepwalking? Because I think we all view it as a bit of a thing that kids do and eventually grow out of, but can it be something that adults deal with? And who's more prone to it, men or women? And is it impacted by things like stress? What sort of brings it on?
Yeah, so sleepwalking, it falls into a different category of sleep disorders. This is in the parasomnia, big fancy word, but it's another type of sleep disorder. And this type of sleep disorder, so sleepwalking, is definitely more common in children. Up to 45% of children sleepwalk. It does soften after puberty, but good 12% of adults do continue to sleepwalk. You're bang on. Stress, alcohol, sleep deprivation, and some medications can exacerbate the number of occurrences of sleepwalking. And what's really important is putting in safeguards, not booking a hotel room on the 5th floor with a balcony that the door opens and you can go out into the balcony, always booking on the ground floor, being really mindful of that. Really mindful if you're a shift worker, just the nature of shift work may exacerbate a condition like this. So putting safeguards in place. And if you do have someone sleepwalking and you have them in the house, previously I think the advice was put them in the shower, wake them up nice and quickly. It's a really mean way to wake up someone.
That's awful.
It's a horrible way. Really, the advice is just to gently move them back to their bedroom, get them comfortable, let them fall back asleep, as that kind of shock can actually exacerbate and prolong the condition.
Sleep disorders, and you've mentioned there are quite a few. They fall under different umbrellas, and in fact, they have their own sort of subsets too, which we do not have time to go into each and every one today. But do they interact with each other? Like we've discussed things like ADHD, anxiety, and depression can all kind of interact with each other. Do we see that with sleep disorders like insomnia, sleep apnea, narcolepsy, sleepwalking? Do they interact together?
They do. They really do. So an individual with narcolepsy is definitely more likely to also have obstructive sleep apnea and insomnia, and some of the nature that disrupted sleep might contribute to that. And the same with insomnia and obstructive sleep apnea. The two can co-occur. If your airway collapses during the night and it causes you to wake up, and then you also have insomnia, now you're awake, this can be quite a vicious cycle. A lot of things, sleep deprivation and stress, will exacerbate the conditions, and so they do co-occur.
Amazing. Thank you to Dr. Maddison for chatting to us about our sleep disorders and clarity on getting enough sleep. Mariam, what do you think about what Dr. Maddison explained there?
You know what? It really does suck how much hormones mess with our sleep, right? Mm-hmm. From puberty, then you go through your menses, then perimenopause and postmenopause. And these constant hormonal fluctuations are just messing with our sleep. Like, when do we get to rest?
When do we get to sleep? It's very unfair.
It's so unfair.
Okay, men might get a bit of sleep apnea, but plug their faces in and they're fine, right?
Yeah, that's right. It's for us, it's just this ongoing, it's just shit.
Hormonal chaos.
Yeah.
It is very unfair. Well, hopefully you found some clarity if you are suffering from a sleep disorder with Dr. Maddison too. I know sleep issues can be really stressful. So please go and see your doctor. As you said, Mariam, don't leave it. Get it sorted sooner rather than later. Mariam, are you ready to whip Carmen into shape?
Sure am.
Look, she's today's quick consult patient. If you are a doctor avoider, which Carmen is, listen up. You're about to get a stern talking to from our good Dr. Mariam.
The doctor will see you now just through here to consult room 1.
It is quick consult time, and today Carmen needs our help to get over an issue she has with her overall health care. So, Mariam, if you could please invite us into the rooms.
Thank you for waiting. How can I help you?
So Carmen knows she has to take care of herself, right?
Yep.
She's aware of this. She does some things, but not a lot of things. Here's what she wrote to us.
Honestly, I'm really scared. I'm 52. I haven't had a health check for a few years, even though I know I need to. No cervical screening or breast screen. Cholesterol, never. Bowel check when the kid arrived in the mail just months from my 50th, also no. Perimenopause, I self-diagnosed when I missed a period for 7 months or so, even though, to be honest, I never kept track of them anyway. I don't know where to start with any of it. I use cost as an excuse, but I'll spend money on injectables, wine, a top skin regime, and hairdressers for the greys. Obviously, if I'm really honest with myself, it is not the cost. It's the fear of judgment and fear generally about going to the doctor. And to be honest with myself, it's more than that. It's the fear of the results. How do I overcome this and get on with looking after my health?
Carmen. So first of all, I want to say you're not alone in feeling this way. So many people put off health checks because of fear, the shame, or they simply just feel so overwhelmed. There's so much to do.
As women too, like we've got a lot of mental load going on, and we have, life admin that keeps us from stuff. Not that we should be using that as an excuse to not look after our health, but it's true.
Right. Yeah, but I do feel like this should come before the greys and the Botox.
It probably should be coming before your Botox, yes.
So my advice would be just pick one, check one. So focus on one thing. So like cervical or breast screening. And just taking that first step is going to be one of the best things that you could possibly do for yourself. It's not about judgment. It's about empowering you to take control of your health and make sure you're looking after your body, just like you would do with your skin and hair, which I'm sure is amazing, by the way. Mm-hmm. So health checks aren't about getting scary results, okay, or getting judged. They're about peace of mind and prevention.
Yeah, because what if the results are good, Carmen?
If
you get your breast screen and they go, all good,
yeah, that's
move on.
right. And most likely that is going to be the scenario. And it's like giving your car a regular checkup. You don't wait for it to break down.
Well,
and it's the same.
Some of us do, but anyway.
It's the same with your body. So I would start by finding a supportive GP. Find someone you trust and feel comfortable with. If you go in and you don't have that vibe, you can find another one. That's completely okay. Acknowledge the fear. It's normal to feel afraid, but not knowing is scarier. You can't change something if you don't know it's there, right? And don't let cost stop you. We all have our priorities, but investing in your health is just as important as all the other things that you're doing. So think of it as your long-term investment in your fund. Freezing your face or wine can't replace good health, unfortunately. And be kind to yourself. Self-care is self-love. So making the appointment is going to be the hardest part, but I promise you, once you go in, you're going to feel reassured, you're going to feel comfortable, and then those other checks are just going to come into play. So just make that appointment. Take a support person with you if that makes things a little bit easier. But get in there, see that doctor, get it done.
Also, Carmen, I don't know if you realise this, but you've already done the first step because you just asked this question.
That's right, yeah. Do you remember that game, Where in the World is Carmen Santiago?
Yes.
Where is Carmen?
Carmen, where in the world are you? Go see the doctor. You've already asked a question. You know it's at top of mind, so go and get yourself checked. If you do have a question for Dr. Mariam, she'll kick you up the butt just like she did Carmen, or if you just need some kind words, because she's very kind too. You do sometimes need some motivation to take better care of yourself. Get your questions in. There's a few ways you can do this. Our Instagram DMs, I've been having some super fun chats with people in there. Through our emails too, which is well@mamamia.com.au. Or if you do want to remain anonymous, we've got this thing called the waiting room. Some brilliant questions coming through there. You can find a link to that in our show notes. Thanks for hanging out in the doctor's office with us again today. Thank you, Dr. Mariam. Of course, all the advice that you've heard today is very general. It is not specific to you, so we cannot stress this enough. Go and speak to your own team of healthcare professionals. And sometimes it does take a team. You might have a GP, but there's a whole bunch of other people out there who can help you as well. So make sure you go and find out from them exactly what is the best option for you. So go make that appointment, Carmen. We're telling you right now. Well is produced by me, Claire Murphy, and our senior producer, Sasha Tannock, with audio production by Scott Stronach and video production by Julian Rosario. And we will see you for your appointment next week.
Bye-bye.
Mamma Mia acknowledges the traditional owners of the land we have recorded this podcast on, the Gadigal people of the Eora Nation. We pay our respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander cultures.
Hi, I'm obstetrician Dr. Patrick Maloney.
And I'm Bridget Maloney. We're the hosts of The Kick, the pregnancy podcast that breaks down everything you need to know about making and growing a tiny human.
We cover it all with expert information and evidence-based discussion based on our experience of running a women's clinic and being parents to 4 boys.
From morning sickness to birth plans, strange cravings to baby movements, listen to The Kick wherever you get your podcasts.